Hello, it's Jenny Geraghty speaking. On behalf of Western New South Wales PHN, I want to welcome everyone to our webinar on the Frailty syndrome. Firstly, I'd like to acknowledge country. I'd like to acknowledge the people of the Wiradjuri Nation and the different nations on which each of our participants meet tonight. I'd like to acknowledge that we work on the traditional lands of many Aboriginal clans and nations and pay respects to elders past, present and future, and acknowledge their continuing connection to the land, water and culture, and ongoing contribution to help shape the life of the communities in which we all work, live and learn. We're committed to working in the spirit of partnership and collaboration with our region's Aboriginal communities and peoples to improve their health, emotional and social wellbeing. I warmly welcome all Aboriginal and Torres Strait Islander Australians who are present tonight. Next step is the housekeeping slide, and the important feature to point out is the little orange arrow at the side of your screen, which allows you to open and close your control panel. And tonight that will be important particularly if you'd like to ask a question, and you can put your question in the questions box. And our intention is to address as many of those questions as we can at the end of the webinar after Dr. Tu's presentation. And just to also let you know that the webinar is being recorded and will be able to be returned to later on if you need any clarification. So without further ado, I'd like to welcome Bill too, who I've briefly been chatting to. Bill's a visiting geriatrician from Canterbury Hospital. He has been coming to Dubbo since about 2012, and he does telehealth sessions and some face-to-face sessions. And so we're very much looking forward to your presentation, Bill.
Thank you very much. This talk is much delayed. We received the invitation to present more than 12 months ago, and initially it was going to be done at a live event, but circumstances over the last 12 months have both prevented me from coming to Dubbo and to present live, unfortunately. But I'd like to thank Jenny, Erica and Liz from the PHN for inviting me to talk. This is a rhetorical question, but I'd like you to think about it as we go along. That is, do you identify which patients in your practice are frail? Next slide, please. There's a dictionary definition of frailty. It's not a medical word, and it's an adjective to describe someone who's weak and or delicate. And we'll go on to describe medical definitions for it, but it's a word that we may have used commonly in a lay sense to describe someone in that condition, but it's been appropriated to describe a geriatric syndrome now. And I do apologise. I think that's a very simple, very descriptive, and very apt definition, and I'm going forwards to complicate that and make it a slightly less easy concept, unfortunately. But we'll see how we go. Next slide. The medical definition now is a condition of decreased physiological reserve, such that there's a reduced ability to withstand perturbations to homeostasis, often associated with reduced muscle mass. That's a long way of saying it's someone who, because of a decrease in their health status, finds it harder to withstand the rigors of illness. And it's often associated with what we call sarcopenia or muscle wasting. And despite this, despite myself being a geriatrician, and despite this having a very geriatric medicine focus, the definition you'll notice is age agnostic. It does not have age as part of its definition. So you could be frail at a very young age, and you can be more robust at a very old age. Because the proportion of people becoming frail is much higher in a geriatric age group, it's commonly described in that context. And geriatricians often define their specialty as the care of the frail older person in particular, rather than all older people, which is why I'm involved in speaking about this. What's important about frailty is that it is a predictor for health outcomes that can be better than using age alone. It can be measured. It may possibly be modifiable, and it should prompt us to frame a person's healthcare through the lens of frailty. And we'll see what that means as we go. Next slide, please. There's a couple of ways of thinking about frailty, and one is by looking at someone's function, and another is by looking at the number of deficits that accumulated. Deficits meaning illnesses in a way. And frailty comes in the spectrum. You can be pre-frail, frail, and very frail. Next slide, please. There is a great overlap with aging in the condition we call sarcopenia. So being frail is associated with what we commonly describe as aging. And maybe a good example of that is when someone who's quite robust, we will say they're good for their age, or if a younger person has had a lot of hard knocks, we would say they look old for their age. And really what we're saying is that they're looking frail. And again, we associate frailty with extreme aging because it is a very common outcome of extreme aging. There are purported subclassifications of frailty, which, examples are cognitive frailty or social frailty. But these are not very well defined in the research sense. They're terms that may be used, but there's no great definition of what that means. So we won't address the subtypes of frailty today. Next slide, please. I just want to just describe geriatric syndromes just for a moment. So because the debate about frailty and what we do about it is not just a healthcare debate, but it's also partly a political one. And part of my talk today is to perhaps raise some awareness about the advocacy role those of us who work in aged care with older people undertake to try and gather some equity, both in the care of the older person and preventing ageism. The geriatric giants were developed to basically highlight conditions for which to which older people are susceptible to or commonly occurs, but for which there were interventions that were possible to improve the outcome. And they are falls, confusion, incompetence, and polypharmacy. Next slide. And they really had a medico-political intent, but by creating, if you like, buzz around those terms, it was a way of directing both political attention, which is funding for care, as well as research attention. And frailty is being raised as an issue within that context. So it's a condition that's, that is being discussed and developed, both because it has potential to be used to describe a person's condition, to modify how they are appropriately cared for, but also as a condition itself, there is the potential, we think, for modifying its status and outcome. And we would like to, in a meta sense, attract attention for funding and also for addressing it as a focus for care. Now, unfortunately, they can cut both ways for our patients. It is, I think, a useful way of looking at a person in order to frame outcomes for which we can prevent harm, improve care. But it's also potentially a way, unfortunately, to discriminate against someone in terms of withdrawing treatments or reducing care or pushing them to one side because of frailty. So we need to be aware of that and just be conscious when we've got our political hats on and advocacy hats on when people are talking about frailty. It's a little bit cryptic at the moment, but we might come to that as we go along in terms of how frailty can affect people in both positive and negative ways. Next slide. Frailty, like all health conditions, has risk factors, and they're rather broad. If you come from a low socioeconomic group, have low education, social isolation, you're an ethnic minority, you have lifestyle factors that promote chronic disease, and biological factors that promote chronic disease in general, then you're prone to frailty. So it's not a very specific risk factor group. Next slide. But the risk factors do seem to hold. The Concord Hospital Aging Men's project, which was an epidemiological cohort study looking at older men around the Concord Hospital catchment, did find that polypharmacy or hyperpolypharmacy, more than 10 medications, were looked at, and polypharmacy was associated with an increased risk of being frail. Interestingly, hyperpolypharmacy wasn't. And it might have been because there were less people with more than 10 drugs, which is hard to believe, or another explanation, but I don't have that as yet. Drug burden index is a measure of how much a particular type of medication was being used, in this case, anticholinergics and sedatives, and that was, again, associated with an increased risk of frailty. And in fact, if you were on those medications, your risk of transitioning from being non-frail to pre-frail increased very significantly. Next slide. And the reason why we're concerned about frailty is because it is associated with poor outcomes. Disability, falls, fracture, and even death. And frailty seems to be, for example, for death, a better predictor than age alone. It shouldn't surprise us that the older you get, the more likely it is that you will have a mortality. You'll die. But in fact, if you look at the survival curves of people as they get to very old age, it's no longer a linear relationship. There's no longer a one-to-one relationship between getting older and the risk of death. It's probably because if you've got the genes and luck from environmental impacts to survive to older age, you are a survivor and you're more likely to keep on living. So in fact, the risk of death becomes slightly lower the older you get. It's still significant, but it's slightly lower. But if you look at frailty versus the risk of death, it's a very, very linear relationship. It's a much better predictor in some senses than age alone. Next slide. Not only does the fact of frailty increase your risk of death, but if your degree of frailty increases, in this case the FI is the frailty index, if your status of frailty increases, then your mortality increases as well, and independent of the fact that you're frail in the first place. So if you're getting frail faster, your risk of death is higher. Next slide. But the risk of frailty isn't absolute. So when you look even, and this is looking at phenotype, so the appearance of frailty model, even in the very old, only about 50% of the 90 to 97-year-olds were actually frail, albeit that a large percentage had a pre-frailty syndrome. But over 10% were not frail, they were robust. So it's not inevitable, but it's certainly much, much more common as you get older. Next slide. And it's a similar outcome when you look at a different way of describing frailty, a frailty index. A frailty index is a deficit accumulation model. So it's basically counting up how many diseases someone has as a measure of frailty. And even when you do that in a 90 to 97-year-old, it's only just over 50% are considered in a frail range. So it's common, but it's not necessarily inevitable that you must be frail at an older age. Next slide. And this slide tells us that there is some plasticity in terms of your frail status. So it's not inevitable that you must stay frail once you are frail. There is some room to move. The room to move is not very large, but there is some room to move. So a 2-year outcome for someone who was frail, there was a small chance of becoming robust and a larger chance of becoming pre-frail, so pre-frailty syndrome. But of course, the risk of death was extremely high at 50%. If you were robust, there was definitely a chance of becoming pre-frail and frail in an older men's group. But if you were robust, the risk of death was much smaller. So that recognizing when someone is frail is important for purposes of prognosis and planning for the future. But it shouldn't be the only determinant of making decisions or guiding someone through decision making. It's requires clinical acumen, nous, and knowing your patient very well. Next slide. So how do you actually identify someone who's frail? Next slide. I've mentioned a couple of terms already, and that was a phenotypic approach and a deficit accumulation approach. And Fried is the researcher who developed the phenotype approach, and Rockwood is the researcher who developed the deficit accumulation approach. And they are very much research tools, but common ways that frailty is defined in the literature. So I think we need to know a little bit about it. And they give some insights into what frailty, they do give some insights to what frailty is. In terms of operationalizing frailty so that it can be used in a clinical sense, frailty or functional scales might be a better way to go in terms of everyday use for you and I. Next slide. The phenotype approach is basically, in simple terms, do you look frail by your function? It's got 5 criteria. Do you have unintentional weight loss? Do you have weakness? Do you exhibit exhaustion? Has your gait slowed, and do you have low physical activity? And they are defined by those numbers. Weakness is generally described by grip strength, which needs a dynamometer. The slow gait is done by a 5-meter walking test, and the other measures tend to be adjusted by sex and, for example, height. Next slide. And the importance of the Fried criteria is because it's examining function. You may have someone who looks frail, and frailty has often been described jokingly as a bit like pornography. You know it when you see it, but it's very, very hard to describe to someone. but it's also something where it's also something that you may not actually see. It's something that may be developing in someone who actually looks okay, but is exhibiting symptoms of frailty, and that's important. So someone may not look frail, but they're developing symptoms of frailty, and that gives us an opportunity to try and address it. If you have 0 of those 5 criteria, you're not frail. But if you even have 1 or 2, you're considered pre-frail, which does have implications in terms of the likelihood of becoming frail later on. And if you have more than 2 of those items, you are considered definitely frail. Next slide. And this was a question posed obviously to a hospital, a medical cohort. And it was a question I posed to my colleagues at Canterbury Hospital, where for a patient that was admitted to hospital, I would suggest the vast majority of them were pre-frail or frail. Otherwise, there'd be some difficulty in justifying why they were in hospital in many senses, and particularly for an older population. One of the difficulties for older people presenting to hospital is that they may not have a condition that strictly warrants their admission to hospital for a medical intervention viewpoint, but their function is such that sending them home is absolutely out of the question because they would not survive due to the function, and that's really a frailty presentation. Chronic disease, acute illness, mental illness can all cause this kind of presentation. It doesn't, the Frailty criteria doesn't tell you what's causing the problem, only what it is causing to the patient. But nonetheless, if you're able to address the individual symptoms that the frailty syndrome presents with, there is a possibility of altering the frailty presentation. Next slide. The Rockwood Frailty Index or deficit accumulation model for medical people often seems more intuitive in the sense that if you've got more medical problems, then you're more likely to be frail. That kind of feels intuitive. The index is defined by creating a list of problems that you think someone might be prone to get, and then counting out how many of those problems the person actually has. And the index is then divided by how many problems they have versus the number of problems you're interested in looking for. A frailty index of 0.25 is considered frail. If you have a 0.5 frailty index, you're considered really quite frail. Next slide. And you can see that the top line is someone with a frailty index of less than 0.1, and the bottom line is frailty index of 0.4. It's a survival curve. So the more frail you are, the more likely it is that something nasty is going to happen to you, regardless of what else you have. And I think this gives some insight into why people become frail. Multiple disease processes may be impacting on a person's organs such that the person has less reserve to withstand medical illness. So you've got a bit of renal failure, a bit of lung disease, a bit of arthritis. When you get the flu, you might not be able to pull through for a variety of reasons, including being able to move freely and avoid the complications of bed rest, etc. And that might be itself alone able to account for why people become frail, but it might also be a separate biological process. Perhaps when you've got multiple diseases, there's an acceleration of the biological aging process, which might be separate from the actual illness process. So some of this theory about why people become frail and how it relates to aging is being worked out. It's not worked out quite at the moment. But at least this model of describing frailty gives some insights into why people become frail. The difficulty, of course, is that this is also a very difficult thing to do. You are not necessarily going to be able to very easily tease out all the problems a person has by taking a history and examining them in great detail every time you see them to determine how frail they are. So, like the 3 criteria, this is largely in the realms of research. Next slide. Now, this is a much more clinical way of describing frailty, and in this case, it's the clinical frailty scale, also developed by Ken Rockwood from Canada. And it's descriptive as well as visual analog. And you can see that someone who scores 1 is very fit and jogging. So, you know, Joe Biden, for example, an elderly gentleman, but frequently jogging to the podium, versus number 3, someone who might be managing well but not regularly active, maybe Mr. Trump walking down the ramp very slowly. And it escalates in terms of degree of frailty. Number 9 is often a confusing picture. It's not actually a person who has gone from being bedbound to sitting in a chair again. Unfortunately, it's a grieving relative. Next slide. And frailty scales or functional scales, you know, which the frailty scale is actually a functional scale, as you can see, we've been using in a variety of disciplines for really quite some time. The ASA is the anaesthetic functional scale, the New York Heart Association functional scale for describing symptoms of heart failure, and the ECOG, which is used in oncology, are all very similar descriptions of function, and they all carry similar weights of prognosis. So someone who is functionally limited has very high risk for adverse events. So the frailty scale, in fact, isn't a new concept. It's describing frailty and function in another way, whereas perhaps we were describing frailty in many ways before, but not calling it that. Next slide. And that might give some validity to that describing frailty in the ways we are has some validity, because those previous scales have validity in terms of determining outcome, either good or bad for patients in terms of where they fall on those scales. So the next question is, how are we managing frail patients? You know, do we manage them in a primary, secondary, tertiary prevention framework? Do we manage phenotype, or do we manage a multimorbidity approach? And what do we do with people at the beginning of frailty? What do we do with people at the end of frailty? And does the health system need to be redesigned to deal with frailty? Next slide. Unfortunately, the strictly assessed frail evidence-based for frailty management is of a reasonably low level of quality. And it's because there's a lack of evidence rather than an evidence of a lack. So it's not really been terribly well studied yet. But this is changing. A lot of research is occurring at the moment. In terms of aged care, generally in the hospital setting, and with a particular focus on perioperative medicine, people undergoing surgery, in terms of how to preserve or rescue them through surgery, but often questions are being asked about appropriateness of surgery and interventions. What was noted when looking at frailty research is it's often conflated with aging, so it's often mixed up with aging. Aging and frailty are often used interchangeably in research, and that muddies the frailty research. It's from a purely research viewpoint, it means that frailty really wasn't studied, it was more around aging. And remember, frailty is meant to be age agnostic. It's not meant to be about getting older. It just happens that as you get older, frailty becomes more frequent. But because frailty is so frequent as you get older, and pre-frailty, we saw in the over 90s group, 50% of people are definitely frail and another 40% are pre-frail. But there does seem to be some justification for using the aged care research evidence to manage frailty, in a sense that since so many of them are frail and we're using an approach to manage frail older people, from a pragmatic viewpoint, it may make some sense to continue using an aged care model for frail people, even though that's not strictly speaking frailty research, it's aged care research. Next slide. So we're going to have a quick look at primary prevention, secondary prevention, and tertiary prevention. Next slide. Primary prevention would not surprise those of you in primary care. It's optimising the social, psychological, biological factors through all courses of life, particularly in early life. There's no particular intervention that I have in mind, but as with much of chronic disease and late life health, what happens in the earlier stages of health seems to be quite important. And often receives the least focus from health in terms of the Department of Health. The Department of Health is, of course, largely concerned with hospitals, which is kind of, you know, when we've missed the boat in terms of prevention, unfortunately. But what primary care does in terms of optimising health, in my opinion, is the most important thing that we can do. But of course, this is a motherhood statement in terms of the specifics. And I apologise for that. Next slide. There are guidelines with regards to what we should do in terms of secondary prevention, and these are the Asia Pacific guidelines. It's a consensus document, but with some evidence base around it. It strongly recommends that we do screen for frailty, so that we can recognise when intervention should be provided. Specific interventions around a physical training program with particular attention to resistance training is recommended. The management of polypharmacy is strongly recommended. Conditional recommendations are made for screening for the causes of fatigue, weight loss, and vitamin D supplementation. And it's conditional because what needs to be considered is the propensity for that person to suffer an adverse outcome from proceeding down a route of intervention for those conditions. As an example, if you're screening for someone for fatigue and you thought that depression or anxiety might be one of the causes for it, you need to be cautious about if you're going to start a pharmacological treatment for that condition. Is that going to be a pro or a con in terms of an outcome? It's usually going to be of a benefit if depression is the cause of their symptom, but if it's going to double their risk of falling over and they're definitely going to suffer an injury, then weighing up those pros and cons can be difficult. So that's why it's considered conditional. Education is not a recommendation simply because there's very little evidence that education alone provides benefit. I think education is something that we should do, and we do in terms of informing people about why we're calling them frail and what we might do about it. But I think what the recommendation says is if you use that alone as your intervention, there is no expectation of success in terms of making a difference about frailty. Next slide. We're going to talk about the phenotype approach to management of frailty predominantly. The multimorbidity approach basically revolves around treating all the conditions that a patient has optimally. The difficulty around that is that guidelines, so individual studies on single organ conditions, heart problems, lung problems, kidney problems, do not at all or very frequently address people with multiple problems. So someone with heart and lung problems, or someone with kidney, brain and liver problems receiving heart failure treatments. They tend to be excluded. So it's difficult to find good evidence about how to manage people with multiple problems at the same time, because they fall outside the trial data. But it is important to examine whether an individual does have a medical condition that is predominantly responsible for their frailty presentation. For example, someone might have a single joint arthritis because of a congenital problem or a sports injury, and that's absolutely responsible for making them lose function, gain weight, and put them at risk of metabolic syndromes, etc. And if you did a joint replacement, you'd actually fix their frailty. Or someone who presents with a cancer presentation where the symptoms that they're suffering from the cancer could be treated, if the cancer was treatable, by an operation that would cure them of their frailty. So making sure you understand what the medical issues are is important, but it can be tricky from an evidence base because the evidence isn't great for treating people with multimorbidity and very frail. Next slide. The phenotype approach, and this is a common approach for geriatric syndromes, is to identify and address the symptoms that the person is suffering from, or the risk factors that the person is suffering from. In the phenotype approach, you might remember there was strength, fatigue, weakness, and mobility type issues. Exercise for frail people can work to address the symptoms of frailty, but because frailty specific research does not have it's not a great mass of research. The quality of the evidence base at the moment is considered low. So although the symptoms may be reversed, it's unsure whether the frailty syndrome will be reversed at the moment, and how much and what type of exercise is absolutely best is still up for research. As I mentioned before, the resistance training, so weight training, seems to have the most research around it, and that can be with elastic band training, or in Sydney there are some specialist clinics that do weight training simply using commercial weight machines. Next slide. Nutritional supplementation may work, but again, the evidence base is reasonably low. And it seems to improve physical performance, but not necessarily weight or body mass index itself. Next slide. Multidisciplinary and multi-component care, which is kind of the mainstay for addressing geriatric syndromes such as falls and delirium. So if you can identify all the risk factors that might be adding up to make someone confused or at risk of falling, and you address them individually, it does reduce the risk of delirium and falls. And it does make some sense that if we did that for the phenotype of frailty, that would have a benefit as such. But as I've said before, the evidence at the moment is kind of mixed up with aging research, so the quality base for that evidence seems reasonably low. Next slide. However, there are some studies that do show some benefits. The FIT trial was done in Australia. It addressed weight loss, it addressed exhaustion, weakness. A geriatrician review was undertaken to look for medical conditions that could be reversed, and compared with usual care, there was an improvement in the phenotypic frailty presentation that was significant. Next slide. Dealing with frailty, also can involve or should involve looking at prevention of harm from people who are frail. Some of the studies looked at a comprehensive geriatrics assessment and medical review when people attended the hospital. One of the, I guess, unfortunate metrics that health departments and administrators sometimes use for people who are frail and often who are older is the representation, reducing representation or emergency admissions. And that's unfortunate because that's kind of a resource usage focus where I think we should be more focused on what the outcome is for the patient. In many ways, it might be a better outcome for a patient in terms of hopefully they were well enough then that they didn't need to come into hospital, or they were able to be provided an alternate care that was more appropriate to their needs rather than being in hospital. But I think it's unfortunate that's the metric, because that can be perverted to finding a way to prevent people who are frail or older from utilising the resource and scoring well on that metric. But nonetheless, there are interventions that can be put into place to reduce the need for hospital care, which might be a good thing. Next slide. A system level approach to improve the care of frail people have been considered, and that does include the projects to try and improve emergency throughput. You don't really want your frail older people to be in an incredibly busy environment where a lot of distractions and interventions occurring rapidly could put them at harm of adverse events. There's often no time to provide for attention to feeding, psychological distress, etc., in an emergency department. So getting them through the department if they need to be somewhere else is of a benefit. Finding ways to do that is good, but preventing them from being admitted because they're frail would be bad. So that's where the advocacy part of looking after older people comes into effect, and having some nuance about what frailty is and how we should manage it. We should always keep it in the forefront of our minds what we want for the frail person and what the ultimate outcome is, not really what we want from the system in the first instance. But the system exists to care for individuals, and so the system is important, but it's individual that still should be in the front of our minds. I have been in meetings where it had been floated, not necessarily seriously, but floated that we should have separate systems, health systems, not nursing homes, but health systems for managing frail people that took them out of our hospitals and provided care in another setting, but which kind of begged the question about what kind of care did you really want to provide these people. My attitude is we should be providing the best care in the system we've got for frail people, rather than removing from the system and finding the expense and loss of efficiency by creating a whole new system again. But that's with my advocacy and political hat on. Next slide. And then my question is, if we created a new system, would it still have equity and justice for the frail person, and would it actually be cost efficient to actually do it? Next slide. For tertiary care, where for tertiary prevention, where frailty is well and truly established and they're very frail, we should be thinking about what that means for their prognosis. And advanced care planning and guardianship and financial affairs is something that we should think about. We should think about through everyone's life course, but of course it's a particular issue there. And frailty can be, and discussing frailty and someone's frailty status can be an entry point to discussing why we're talking about end-of-life care situations. And the evidence around frailty being a marker for poor prognosis rather than just age can be an objective way, in the sense of initiating discussion about these these strategies. And treating people with a different health outcome or ceiling of care or health objective is not a denial of a treatment or trying to prevent treatment, but a change of strategy. And probably the best example I've got of how that's done really well is the renal physicians now who have a renal replacement therapy approach. So they've got people who are really clear to them would benefit from dialysis for one reason or another, maybe to tide them over to a transplant event. And people who really aren't for a renal replacement therapy, where putting them on dialysis is going to impair their quality of life. And for these people, for these patients under renal management, it doesn't matter which pathway they're under. They continue with the same physician. They're offered active management, but appropriate to their needs, and they're not abandoned. And there is evidence in the renal literature that when someone who is being looked after and is not offered renal replacement therapies, their quality of life is often improved compared to people on dialysis. So dialysis is used as a bridging tool to something better, such as a transplant. Next slide. And when we are developing advanced care directives, and what we're really trying to do is describe, understand the person's health goals and objectives. And we're being agnostic about. We're not trying to project what we would want onto them. We're simply accepting what it is they want. But we need to put that in the context of what the medical boundaries are of what we can achieve. So a person may want to have an amputation of their little toe to treat appendicitis, but we're not going to do that because that's not a treatment for appendicitis, for example. So there are medical boundaries in terms of what they want, but it's really about listening to what the person wants. It's very different from doing an end-of-life care discussion. An end-of-life care discussion is really focused on making sure the person knows the end of life is coming and preparing them for it. But an advanced care directive is really making sure the person understands what their health goals are and accepting what their wishes are within that context. But it's often a very contradictory process, and a lot of the process is trying to disentangle the contradictions in what they're saying they want. Someone who doesn't want surgery but doesn't want to die of appendicitis would be an example. Next slide. So my thoughts are that Frailty puts a name to an overlay we put on our patients to help guide a management path, which might include prevention of frailty, but also puts in the context all their other diseases and how we might manage that in the context of what the frailty prognosis gives them. And I think most of us do that already. When we see someone who looks crumbly, we have a slightly different pathway of someone who looks really robust. But few of us do that in a formal way, in the sense of doing a frailty scale and then putting them on that scale. The frailty scale, though, is fairly intuitive. So even though we don't use a scale, I'm not actually particularly upset for those of us who can recognise where someone is on that scale. I think we do it intuitively. Next slide. But there are controversies with frailty, and one of the things are we simply medicalising the natural life course? As I said, it puts potentially our patients at risk of a new type of ageism, which is calling someone frail and therefore making decisions about what kind of healthcare they should have, perhaps inappropriately, without understanding that there are, it's not an end of treatment sort of process. There might be reversibility, and we need to continue providing care to them. And there is a paucity of high quality research because of the contamination, ironically, by geriatric medicine research. But there is a question about whether it matters in a pragmatic sense at the moment. We know the approach geriatric medicine conditions generally works, and why shouldn't we continue to use them, even though we haven't defined frailty very clearly in the literature. And we need to have a transition from measuring to doing, which is lacking at the moment. So I think frailty is useful. I think it's something that has value to us, and it may be more important than simply looking at someone's age. but we need to be careful about how it's being used. And when we're hearing people, including myself, talking about frailty and what we should do, to ask yourself, would we be saying that if we were using age instead of frailty? Is it the kind of thing that that potentially could be discriminatory, or is it medically useful? And I think that's the end of the talk, Jenny.
Thank you very much, Bill. That was very interesting. And I think the concept of frailty it has got a lot of nuance about it, particularly when you talk about the fact that it can be sort of age and frailty can get mixed. So I have a few questions. One of them was the frailty scale. The frailty scale from Canada, developed by Rookwood, looked like an easy scale to use. Would you necessarily recommend GPs use that as a routine?
It is recommended to use, but having said that, even in my practice, we don't use the frailty scale at all as a screening tool. The frailty scale, though, has the advantage of being very, very intuitive. In terms of it describes in pictures and words kind of what we see in patients walking through the door. So it is a useful. I think it is a useful thing to use. I guess where the benefit is may not be necessarily in where they are when you see them walk through the door, but if you do a comparison to where they were a year ago when they walked through the door, that might give you an insight in terms of this person's in trouble or about to be in trouble, and we need to do an intervention now. So if you've got a long-term relationship with someone, I think it would be useful. It would be useful to use in that regard, not necessarily from telling you this person's frail or not frail, but where they're going in their trajectory.
Got it. At the 75 plus health check, GPs are encouraged to do or to touch upon issues like the advanced care directive, guardianship and power of attorney. Is, again, at that assessment, is sort of categorising people as robust, pre-frail or frail something that we should be thinking about doing?
I think it's helpful. I think it's helpful for two reasons. So number one, of course, you want to pick people who are starting to show functional problems in some way, so that you can try and reverse that, try and keep them as healthy as possible. And picking up when someone's starting to slide, I think is important. As I said, they may, the functional scale, the phenotype description, which is actually, I think it's very difficult to apply, but it's useful in the sense that someone may not look frail, but they're starting to exhibit symptoms that might make them become frail later on. And what that tells us is someone may be developing frailty, but it might be slipping sort of underneath the radar in primary care. We're trying to look after them. So I think it is important to do. But if you do it for the first time when they're 75, it can be a little bit difficult to know what the trajectory of the frailty is. Is it something that they've been frail for a long time and it's not really getting much worse, or are they getting frail more quickly? You've done it for a couple of checks before that'll give you a better idea. But nonetheless, if they are in the frail group at the time, you don't know what the trajectory is, but they're in the frail group at the time you're doing the check. That gives you an inroad to saying, look, you're this on the scale. We kind of know that this has implications for your future in this regard, and maybe we should start thinking about what kind of plans you might have and what your goals are for your future if you know this is the category you're in. So I think it might be useful in advanced care planning in terms of giving that into the conversation. It can sometimes be hard to do.
Yes, sort of frame a conversation around that. And
It's why, you know, I'm sure we're told to do it, but this is a good reason why we should do it.
Exactly. Yep. From what you've said this evening, once frailty is diagnosed, there's perhaps a little bit that can be done to reverse that, but not a lot. But in preventing frailty, is it correct? It is things like managing chronic illness well, advising against smoking, exercise, being socially connected. They're the sorts of things that if we're educating our patients about, we might help them avoid frailty. Is that correct? And also thinking very carefully about how we prescribe.
Now, yes, that does seem to be the case, and it's just not very high powered in the sense that that's all the things that, you know, all of us should be doing all the time. But at the same time, we hope that it will be an intervention that should reduce frailty. If you can reduce someone's chronic disease burden, then you can reduce the amount of illnesses they have, and that will impact on their frailty index, for example. So yes, it makes sense, but it seems so obvious, particularly to you in primary care, that it almost seems embarrassing to tell you that what you're doing is what you should do. So so that's why I hesitate about that. But I think, you know, you may be aware that each cohort of population, as we go into the future, are getting healthier and healthier. We're living longer. There's less dementia in cohorts as we go. So, you know, if you're born in the 20s, you've got a better risk of dementia and living longer compared to born in the 1900s, for example, and the people born in the 40s are better in the 60s, etc. And that's all due to public health and primary care. It's not due to what the specialists are doing at the end of the road. It's kind of what has been happening on a public health level and the community level right from early on. So there are benefits that we are already reaping and seeing the rewards from improvements in primary care and public health as we've been going along. But it's not it's not stuff that I can tell you specifically what you should do. It's more like keep doing what you're doing really well.
It's a good note to end on, Bill. A positive note. Yeah. Well, I think we've come to the end of our session this evening, and I really want to thank you for a very thorough and informative talk about a concept that maybe we hadn't thought of so much as a concept, but as you say, in general practice, we've probably been doing in our everyday work as much as we can do to prevent it and optimise the care of people who may be coming pre-frail or frail. So I want to thank you very much for that. And to the attendees, your feedback, as this slide says, is very, very much valued. And I'd just like you to, if you can, take a moment, use the QR image and give us your feedback. And I think we're just about finished, unless there are no more questions, I think. So yes, thank you very much, and thank you, Bill.
Thank you all, and good night.
Thank you, Bill.